Hey everyone, and welcome back. Today we're going deep into antibiotic allergies.
Oh, yeah.
And I think it's good as medical microbiologists.
Yeah.
This is a really big deal for all of us.
Absolutely.
So today we're going to be taking a deep dive into the AWARE book on antibiotic stewardship
Okay.
from the World Health Organization.
Sounds good.
So get ready to bust some myths.
Yeah.
Because what we think we know about antibiotic allergies
Right.
might not be the whole story.
It's true.
So to start,
Yeah.
maybe we can just lay the groundwork
Sure.
with some definitions.
Yeah, that's a great place to start. Chapter 3 of the AWARE book actually really lays that groundwork.
Perfect. So when we say allergy
Right.
versus like a bad reaction
Yeah.
to medication.
So an allergy is a very specific thing.
Okay.
It's a specific immune response
Okay.
to something that the body thinks is foreign.
Okay.
So it's not just any side effect.
Right.
An adverse reaction is any bad or unexpected response
Got it.
to a drug, whether it's the immune system.
Okay.
So
not all bad reactions are true allergies.
exactly.
That's already myth-busting number one.
That's right.
I love it. And the AWARE book
Yeah.
goes on to break these down even further into type A and type B.
Okay.
And the key takeaway here is that most patients are experiencing type A reactions,
Got it.
which are predictable based on how the drug works.
So like nausea or...
Yeah, like nausea, diarrhea, those kinds of things.
Okay.
Unpleasant, but not truly an allergy.
So a true antibiotic allergy
Yeah.
would be these type B reactions.
That's right.
So unpredictable and really like the immune system's going haywire.
Exactly. And even within type B,
Yeah.
there's a whole spectrum.
Okay.
There are things called immediate reactions,
Okay.
like anaphylaxis,
Right.
which happen within a couple of hours.
Okay.
And then there are delayed reactions,
Yeah.
which can take,
Okay.
more than 24 hours to show up.
So how common are true antibiotic allergies?
Because it feels like we hear about penicillin allergies
Right.
all the time.
Well, this is where it gets really interesting.
Okay.
So in high-income countries, something like 5 to 15% of people report a penicillin allergy.
Wow.
But get this, studies suggest that over 95% of those people
What?
probably don't have a true allergy.
That's a huge difference.
It is a huge difference.
Wow.
And think about what that means for antibiotic stewardship.
Right.
So if clinicians are afraid to prescribe certain antibiotics,
Yeah.
they might end up using less effective or even more toxic options.
Right.
And that's not good for patients, and it fuels antibiotic resistance.
That makes perfect sense.
Yeah.
So how do we know if someone is having a true allergic reaction
Right.
versus just a side effect?
Well, the clinical presentation can really vary,
Okay.
but it's really important to remember that things like GI issues
Good.
and headaches are usually not signs of a true allergic reaction.
Interesting.
Yeah. So those are more likely to be side effects.
Got it.
Or something else entirely.
Okay.
True allergic reactions
Yeah.
can range from mild skin reactions like hives
Okay.
to severe life-threatening symptoms.
Okay.
So for example, anaphylaxis
Yeah.
is that really rapid onset multi-system response.
Okay.
It can involve airway constriction,
Oh, wow.
difficulty breathing,
Right.
drop in blood pressure,
Okay.
even loss of consciousness.
That sounds terrifying.
It is.
Okay.
And then on the other end of the spectrum,
Yeah.
you have the delayed reactions.
Okay.
And these can also be severe
Okay.
with symptoms like painful skin rashes, fever, joint pain, and even organ involvement.
Organ involvement.
Yeah.
That's serious.
It can be.
Wow.
And, the severe delayed reactions can affect the liver or kidneys.
Okay.
So we're looking for signs of things like hepatitis or nephritis.
There's a lot more to this than I realized.
There is.
So let's say a patient comes in
Okay.
with a history of penicillin allergy.
Yeah.
What's the next step?
Yeah.
Do we automatically send them for allergy testing?
Well, not necessarily.
Really?
The AWARE book actually challenges that common practice.
That's surprising.
It is, and it says that routine skin testing
Okay.
before prescribing beta-lactams
Right.
isn't always necessary.
Okay.
And they say that it can actually be a barrier
Okay.
to using these important first-line antibiotics,
Oh.
especially in places where resources are limited.
That makes sense.
So instead,
Yeah.
they really emphasize focusing on
Okay.
getting a detailed history
Okay.
and doing a careful risk-benefit assessment.
Okay. So how do we actually go about evaluating a potential allergy?
So the first step is taking that thorough history.
Okay.
When did the reaction happen? What were the specific symptoms? Have they been exposed to that antibiotic before?
Got it.
And this helps us categorize patients into low, moderate,
Right.
or high risk.
So give me an example, like what would put somebody in each one of those categories?
Sure. So someone who reports, a mild upset stomach
Yeah.
after taking penicillin would probably be considered low risk.
Hey.
A history of hives or a non-severe rash might be moderate risk.
Okay.
And then someone who experienced anaphylaxis or a severe delayed reaction
Right.
with organ involvement would definitely be considered high risk.
Okay, so we've got our risk categories.
Yeah.
What then do we dive into lab tests at this point?
Let's explore that next.
Perfect. I'm all ears.
It's fascinating how lab tests can add another layer to this whole process.
Okay.
Yeah, so when it comes to lab tests, it's not a one-size-fits-all approach.
Okay.
The AWARE book also talks about this in Chapter 3.
Got it.
So there are clinical tests.
Okay.
Microbiology tests, other lab tests, and even imaging can play a role.
Okay, so that's quite a range.
It is.
So let's start with the clinical tests.
Sure.
What exactly are we talking about there?
So think of it as an extension of that detailed history we
Right.
were talking about. So we're evaluating the patient's physical signs and symptoms,
Are you?
looking for anything that supports or refutes
Oh,
our suspicion of an allergic reaction.
so really connecting the dots between their story
Yeah,
and what we're actually seeing.
exactly.
Right.
So for instance, if we're concerned about an immediate reaction,
Okay.
things like vital signs, blood pressure, heart rate, respiratory rate,
Okay.
super important to monitor.
Got it.
Those can give us early clues about a severe systemic reaction, like
Okay.
anaphylaxis.
Right.
We also want to look at the skin
Okay.
for things like hives, angioedema, or other rashes.
Makes sense. So what about the microbiology tests?
Yeah,
I'm assuming those aren't really directly diagnosing the allergy itself.
you're right. They're more about identifying the culprit
Okay.
behind the infection.
Okay.
So this helps us choose the most appropriate antibiotic,
Right.
regardless of any allergy concerns.
So getting that right bug-drug matchup,
Exactly.
even if an allergy is suspected.
Yeah, so for example, let's say a patient has a reported penicillin allergy,
Okay.
but their infection is caused by bacteria
Uh-huh.
that are highly susceptible to penicillin.
Okay.
So knowing that might actually sway the decision
Okay.
to use a penicillin class antibiotic,
Got it.
even with the allergy report,
Interesting.
especially if it's the best option for that particular bug.
So it all comes back to that risk-benefit analysis.
It does.
We can't just like blindly avoid an antibiotic without considering the whole picture.
Right.
So you mentioned other lab tests earlier.
Yeah, bid.
What falls into that category?
So there are certain blood tests
Okay.
that can give us more information
Okay.
about what's happening immunologically.
Okay.
So for example, a CBC
Okay.
can show us elevated levels of eosinophils.
Eosinophils.
Yeah.
Those are the white blood cells that are often associated with allergies.
You got it.
Okay.
So if we see that,
Yeah.
it could be a sign
Okay.
that the reaction is truly immune-mediated.
So it's like we have an objective measure to kind of back up our clinical suspicions.
Exactly.
Mm.
Another test to consider is serum tryptase levels.
Okay.
So tryptase is an enzyme released by mast cells,
Okay.
which are key players in allergic reactions,
Okay.
especially anaphylaxis.
Okay.
So elevated tryptase levels can help confirm anaphylaxis,
Got it.
even if the clinical picture isn't completely clear.
Okay, that makes sense. So what about imaging?
Yeah.
Does that have a role in evaluating antibiotic allergies?
So imaging is usually less useful
Okay.
for immediate reactions,
Got it.
but it can be helpful in assessing organ involvement
Okay.
from those delayed reactions we talked about earlier,
Right.
particularly if the liver or kidneys are affected.
Okay.
So for example, if we suspect hepatitis or nephritis,
Uh-huh.
we might order something like an ultrasound or a CT scan.
So the imaging is really helping us see the potential consequences
Right.
of the reaction, not necessarily diagnose the allergy itself.
Exactly. It helps us understand the extent of the reaction
Nothing
and
more.
make informed treatment decisions.
Got it. So we talked about recognizing these reactions,
Right.
doing this thorough evaluation.
Yeah.
What about actually treating antibiotic allergies?
Okay.
What does the AWARE book say about that?
So treatment always depends on the severity and the type of reaction we're
Yeah.
dealing with. So for mild reactions
Right.
like localized hives or itching, antihistamines are often enough
Okay.
to relieve the symptoms.
So those are just the over-the-counter meds that people use for seasonal allergies.
Exactly.
Yeah.
And they work by blocking the effects of histamine,
Right.
which is a chemical released during an allergic reaction
On it.
that causes all that itching and swelling.
Makes sense. What about more serious reactions?
Yeah.
Like angioedema or anaphylaxis?
So those are definitely situations
Yeah, those sound pretty scary.
where we need to act fast.
Okay.
And the go-to treatment in those cases is epinephrine.
Really? Also known as adrenaline.
I've heard epinephrine is like a lifesaver in those situations.
It absolutely is.
Okay.
It works quickly to counteract the effects of anaphylaxis,
Right.
opens up the airways,
Right.
raises blood pressure,
Okay.
and basically stabilizes the patient.
Okay.
And it's often given as an autoinjector like an EpiPen,
Right.
which people who are at risk for severe allergic reactions can carry with them.
So EpiPens are really crucial for anyone with a history of severe antibiotic allergies.
Right.
What about those delayed reactions?
Yeah.
How are those typically managed?
Again, it depends on the severity
Right.
and the specific symptoms.
Okay.
So for mild skin reactions, topical corticosteroids
Okay.
can help reduce inflammation and itching.
So kind of like treating a poison ivy rash.
Yes, exactly.
Okay.
But for more severe cases,
Yeah.
we might prescribe systemic corticosteroids,
Okay.
like prednisone,
Got it.
to suppress the immune response
Right.
and really get those symptoms under control. So it's like turning down the volume on the immune system's overreaction.
Exactly.
Okay, so we've covered identifying these reactions,
Right.
treating them.
Right.
What about the actual antibiotics that tend to cause the most trouble?
Yeah.
Which ones are we most likely to see allergies to?
That's a great question.
Yeah?
And it leads us right into a discussion of specific antibiotic treatments.
Perfect. Let's dive in. All right, so let's talk about the antibiotics themselves.
Okay.
Which ones are the usual suspects when it comes to allergies?
So the most common culprits are the beta-lactam antibiotics,
Okay.
which include penicillins and cephalosporins.
Right.
And these antibiotics share a common structure
Okay.
called the beta-lactam ring,
Uh-huh.
and that's often what triggers the immune response.
So if someone's allergic to penicillin, are they automatically allergic to all beta-lactams?
Well, not necessarily.
Okay,
There's
right.
definitely a potential for cross-reactivity
Okay.
among beta-lactams, but the risk isn't always high, especially between penicillins and other classes like cephalosporins and carbapenems.
So it's not like a blanket ban situation.
Right, we have to assess the risk of cross-reactivity
Right.
based on the specific antibiotic
Okay.
and the patient's individual history.
So knowing the specific antibiotic and the patient's history is key.
Absolutely.
Now, I'm also curious about the how behind these reactions.
Yeah.
What's actually going on in the body when someone has an antibiotic allergy?
The pathophysiology.
Yes.
So it's all about the immune system.
Okay.
So it can get pretty complex.
Okay.
Basically, the body mistakenly identifies the antibiotic or a part of it as a dangerous invader
Okay.
and launches an immune response.
Okay.
And this can involve different types of immune cells,
Right.
like mast cells, T cells, and B cells.
So it's like the immune system is overreacting,
It is.
something that's not actually a threat.
Right.
And so the specific mechanisms can vary depending on the type of reaction.
Exactly. So immediate reactions like anaphylaxis
Yeah.
are usually driven by IgE antibodies,
Okay.
which bind to mast cells
Right.
and trigger the release of histamine and other inflammatory mediators.
So that's why antihistamines and epinephrine are so effective in those cases.
That's right,
Okay.
because they're targeting these key steps
On it.
in that allergic cascade.
Okay. What about those delayed reactions?
Yeah,
Are those driven by the same mechanisms?
not quite.
Okay.
Delayed reactions often involve T cells,
Okay.
which are a different type of immune cell
Right.
that can directly attack cells.
Okay.
They perceive as foreign or infected.
So it's a different arm of the immune system at play.
Exactly.
Fascinating. It's different mechanisms, different treatments.
Yeah.
It's all starting to come together.
Yeah.
Now, are there certain people who are more prone to antibiotic allergies?
That's a great question.
Yeah.
So antibiotic allergies can happen to anyone,
Okay.
but there are definitely some risk factors.
Okay.
People with a personal or family history of allergies, like asthma, eczema, or hay fever,
Right.
are more likely to develop antibiotic allergies.
So there's a genetic component to it.
It seems so.
Okay.
And another big risk factor is frequent or prolonged antibiotic use.
Okay.
So the more you're exposed to antibiotics,
Yeah.
the higher the chance your immune system will develop a sensitivity.
Makes sense. It's like the immune system's getting sensitized with repeated exposure,
exactly.
which brings us back to the importance of antibiotic stewardship.
Absolutely.
All right.
Using antibiotics only when they're truly necessary
Right.
can help prevent allergies
Yeah.
and preserve the effectiveness
Yeah.
of these essential medications.
We don't want to be creating more problems down the road.
Exactly.
Okay, so before we jump into some exam-style questions to really test our knowledge,
Okay.
I'm curious about the most common pathogens we encounter.
Sure.
In clinical practice, What are the usual suspects that medical microbiologists like ourselves are dealing with?
So it really depends on the clinical setting and the type of infection.
Okay.
But some frequent culprits include Staphylococcus aureus,
Okay.
Streptococcus pneumonia, Escherichia coli, and Klebsiella pneumonia.
The classics.
Yes.
Are any of those particularly notorious for antibiotic resistance or a link to allergies?
Yeah, so Staphylococcus aureus,
Okay.
especially methicillin-resistant Staphylococcus aureus, or MRSA,
Right.
is a big concern because of its high rates of antibiotic resistance.
Right.
And this often forces us to use broader spectrum antibiotics,
Right.
which, as we discussed, can actually increase the risk of developing allergies.
It's a vicious cycle.
It is.
All right, I think it's time to put all of this knowledge to the test.
Okay.
Ready for some exam-style questions?
Bring mine.
Okay, first question. A patient comes in with a history of a mild rash a few days after taking amoxicillin for a sinus infection 5 years ago.
Okay.
They now need antibiotics for a urinary tract infection.
All right.
What's the best course of action?
Okay, so first we need to consider if this patient truly has a penicillin allergy.
Right.
So the fact that the rash appeared a few days after taking the amoxicillin and was mild
Okay.
suggests a delayed, probably non-IgE-mediated reaction.
Am I?
Plus, it happened 5 years ago,
Right.
which makes a severe reaction upon re-exposure less likely.
So probably a low-risk situation based on their history.
Exactly, and they need treatment for a UTI.
Right.
And beta-lactams are generally the first choice
Okay.
for uncomplicated UTIs, and they have a good safety profile.
So given the low allergy risk and the effectiveness of beta-lactams,
Right.
for this type of infection, it seems reasonable to go ahead and use one.
I agree, and of course we want to inform the patient about the potential, albeit low risk of a reaction.
Right.
And tell them to seek medical attention immediately
Of course.
if they experience any concerning symptoms.
Right.
But avoiding a potentially effective treatment
Mm.
based solely on that distant history of a mild reaction
Right.
would be an overreaction and could lead to suboptimal care.
That's a great point.
Yeah.
It's all about finding that balance
Yeah,
between caution and making sure the patient gets the best possible treatment.
absolutely. And this scenario really highlights the importance of a thorough allergy assessment and making those decisions on a case-by-case basis.
All right. Ready for the next challenge?
Hit me with it.
A patient with a reported penicillin allergy comes in with signs and symptoms of pneumonia.
Okay.
Microbiology testing shows the culprit is Streptococcus pneumonia,
All right.
which is known to be highly susceptible to penicillin.
Right.
But the patient's allergy history is poorly documented,
Okay.
and we don't have details about the previous reaction.
Got it.
What's the most appropriate next step?
So that's a classic clinical dilemma. You have a patient with pneumonia.
Right.
You know, the bug is susceptible to penicillin,
Yeah.
but there's that reported allergy hanging over our heads, and
Yeah.
we don't have all the information we need.
So what do we do? Go ahead with the penicillin anyway. Or play it safe and choose a different antibiotic.
So in this case,
Yeah.
where the allergy history is murky,
Okay.
we need more information
Okay.
before making a decision.
Got it.
So the best next step is to really dig deeper into that patient's previous reaction.
Okay.
We might contact previous healthcare providers,
Okay.
review old medical records,
Right.
maybe even consult with an allergist if possible.
Makes sense. So we can get a clearer picture of that previous reaction
Exactly.
and then determine the level of risk
Right.
and really let that guide our antibiotic choice.
Yeah, so if we find out the reaction was low risk
Okay.
and the benefits of using penicillin outweigh the risk,
Yeah.
then we could consider using it
Okay.
with close monitoring, of course.
Right.
But if the history remains unclear
Right.
or suggests a high risk of a severe reaction,
Okay.
then choosing an alternative antibiotic would be the safer route.
So it's really a judgment call based on the available information
It is.
and that careful risk-benefit analysis. No easy answers here.
Right. And this emphasizes the importance of clear documentation and communication
Oh, yeah. Big time.
when it comes to allergies,
For sure.
because vague or incomplete allergy reports can
Yeah.
make it really difficult to manage these patients
Right.
and choose the best treatment.
Okay. Ready for one last brain teaser?
Let's do it.
A patient is admitted to the ICU with suspected sepsis.
Okay.
They have a history of a severe immediate allergic reaction to penicillin
Okay.
that required epinephrine.
All right.
The infectious disease team recommends starting broad-spectrum antibiotics
Yeah.
while waiting for culture results.
Okay.
Which antibiotic class would be the best choice in this scenario?
All right, so this is a high-stakes situation.
Yeah, for sure.
We need to think carefully and act fast.
Right.
So we have a critically ill patient
Mm-hmm.
with a history of anaphylaxis to penicillin,
Okay.
which is a beta-lactam antibiotic.
Right.
We need to get broad-spectrum antibiotics going.
Yeah.
But we absolutely can't risk another allergic reaction.
So beta-lactams are out of the question
100%.
because of that anaphylaxis history.
With a severe IG-mediated reaction like that,
Right.
we have to avoid all beta-lactams,
Okay.
including cephalosporins and carbapenems,
Right.
because of the risk of cross-reactivity.
Got it.
Patient safety comes first.
Absolutely. So we need a broad-spectrum antibiotic
Yes.
from a different class. What are our options?
So in this case, we'd want to go with a non-beta-lactam.
Okay.
That's effective against both gram-positive and gram-negative bacteria.
Okay.
So fluoroquinolones,
Okay.
like ciprofloxacin or levofloxacin, could be a good option.
Okay.
They have a broad spectrum of activity
Right.
and are generally well tolerated.
Okay.
Another possibility is a combination of antibiotics,
Okay.
like vancomycin, which targets gram-positives,
Right.
and an aminoglycoside like gentamicin,
Okay.
which is effective against gram-negative.
So those are some good options, but I'm guessing each one comes with its own set of considerations.
You're right.
Yeah.
So fluoroquinolones can have side effects,
Okay.
like tendon rupture and QT prolongation,
Okay.
which is a heart rhythm problem.
Right.
Aminoglycosides can be tough on the kidneys.
Right.
So the best choice really depends on the patient's individual medical history,
Okay.
their kidney function, and what we suspect is causing the infection.
So again, it's about weighing those risks and benefits of each option
Yeah.
to find the best fit
Exactly.
for that specific patient.
And with a critically ill patient,
Right.
close monitoring for any side effects is crucial,
Right.
regardless of which antibiotic we choose.
Wow, those were some tough questions.
Yeah.
But you nailed them.
I think our listeners have learned a lot
I think so too.
from this deep dive.
I hope it empowers everyone to approach antibiotic allergy assessments
Yeah.
with more confidence and precision.
Me too.
It's all about patient safety
Right.
and responsible antibiotic use.
Absolutely.
Well said.
Thanks.
Accurate allergy assessment isn't just about avoiding bad reactions.
Yes, right.
It's about making sure everyone gets the right treatment
Yeah,
at the right time.
exactly.
That's a wrap for today's deep dive.
Thanks for having me.
Until next time, stay curious and keep exploring the amazing world of microbes.